Hi, I'm Donna Edwards, and I'm going to be discussing with you treatment of stimulant use disorder. The issue in brief, stimulant use disorder include a range of problems associated with the use of methamphetamines, cocaine, and other amphetamines. Diagnosis of stimulant disorder is based on the occurrence of at least two of the following within the 12-month period. Taking more stimulants than intended, failing to cut down or control the use of stimulants despite wanting to do so, spending excessive amounts of time in activities surrounding stimulant use, experiencing urges and cravings for stimulants, failing to meet the obligations of home, school, or work, continuing to take stimulants even if it has led to relationship or social problems, giving up or reducing important recreational, social, or work-related activities because of stimulant use, using stimulants in situations which is physically hazardous, continuing to use stimulants even if there is an awareness that it is causing or worsening a physical or psychological problem, experiencing an increase in tolerance to stimulants, and having withdrawal symptoms when not taken. Cocaine misuse is the highest among adults aged 18 to 25, while methamphetamines misuse is the highest among those aged 26 to 49. Methamphetamines misuse rates are particularly high in American Indians and Alaskan natives who, according to the Center of Disease Control and Prevention data, also have the highest risk for methamphetamines-related overdose and deaths. This data show that Black or African American communities have the highest risk for cocaine-related overdose deaths. Impact of the problem. Short-term impact. The short-term effects of stimulant use vary depending on several factors, including combination of substance used, route of administration, potency, dosage, and level of prior use. However, in broad terms, stimulants are known to cause increased wakefulness, reduced appetite, and feeling of euphoria brought on by the rapid release of the neurotransmitters, including dopamine, serotonin, and norepinephrine. Stimulant overdose can cause other serious symptoms, including hypertension, fainting, seizures, and death. As is evident by overdose data, the number of stimulant overdose resulting in death are climbing dramatically. Long-term impact. Chronic stimulant use may result in a number of health issues. The long-term persistent hypertension and the host of other serious cardiovascular complications can occur, such as angina, valvular disease, stroke, and an increased risk for a heart attack. Chronic stimulant use can permanently alter brain structure, leading to impaired cognitive, neurological, and emotional systems. Because stimulant use releases large amounts of dopamine and serotonin, chronic use may cause mood fluctuations, anxiety, and depression, even when not taking the drugs. Long-term use of cocaine and methamphetamines can decrease attention, confusion, impaired memory, inhibit impulse, and reduce motor skills. These long-term impacts pose challenges for recovery, but successful treatment can enable people to return to a productive and meaningful life. Impact on society. Stimulant use also has detrimental society effects, including negative outcomes for children who have a parent who uses, heightened crime in communities, costs associated with enforcement and incarceration, environmental damage, and premature death. Association with risky behavior. People who use stimulants are more likely to engage in unprotected sex and sex with multiple partners. In addition, intravenous administration of stimulus may result in reassuring or sharing needles, syringes, or other paraphernalia. These behaviors place people who misuse stimulants at higher risk for HIV and other blood-borne pathogens such as hepatitis B and hepatitis C. This is a concern because chronic stimulant use is linked to a weakened immune response, increased susceptibility of infection, and accelerated retroviral replication. What research will tell us? Motivational interviewing, contingency management, community reinforcement approach, cognitive behavioral therapy. Practice selection. To be considered for inclusion in this information, enable practices had met the following criteria: must be clearly defined and replicable, address stimulant misuse reduction as a primary outcome, are currently in use, provide evidence and effectiveness, have accessible resources for implementation and fidelity. Identification of practices associated with treatment of stimulant use disorder is motivational interviewing. The goal for motivational interviewing is a treatment approach that helps individuals outcomes ambivalent feelings and insecurities. In the process, individuals become motivated to change their behavior and reduce or stop their stimulant use. Developers of motivational interviewing defined it as a directive, client-centered counseling style for eliciting behavior change by helping clients explore and resolve ambivalence. 5 underlying principles guide how providers should interact with clients while using this practice. Providers should express empathy through reflective listening, identify discrepancies between the client's goals or values and their current behavior, avoid arguments and direct confrontations with the client, adjust to a client's resistance rather than opposing it directly, support self-affecti and optimism. In a typical setting, motivational interviewing is effective in a wide range of healthcare settings, from primary healthcare clinics to general specialized hospitals. Studies include in this evidence review test the effectiveness of MI for treating people with stimulant use disorders in walk-in healthcare clinics, urban trauma centers, private or university-run health clinics, community-based health clinics, and community-based sites. The demographic groups for intervention. Motivational interviewing is intended for across genders, ages, races, and ethnicities. This counseling approach can also be used with specific groups within the population, such as men who have sex with men. The outcomes associated with motivational interviewing studies include in this evidence review demonstrated that the use of MI for people with stimulant use disorders was associated with reductions in the number of days of stimulant use, amount of stimulant use per day. All outcomes were measured using either urine toxicology or participant self-report. The time between treatments and the follow-up varied from 0 months immediately post-treatment to 6 months. The studies typically included adult participants who were aged 18 and older, had no language barriers, and met criteria in the Diagnostic of Statistical Manual of Mental Disorders, the DSM, for stimulant use disorder either through screening or self-report. Individuals with cognitive impairment, serious mental illness, suicide risk, or inability to provide informed consent were not included in these studies. This evidence review also includes studies each of which include the following participant characteristics: adolescents and younger adults ages 16 through 22, men who had sex with men, individuals who exhibit co-occurring psychiatric disorders not requiring acute inpatient psychiatric services, patients with intentional and unintentional traumatic injury. The practitioner types used, the motivational interviewing, is intended for by a wide variety of practitioners, including primary care and behavioral health professionals, peer providers, and criminal justice personnel. Training on motivational interviewing is available for clinicians, non-clinicians, peers, and those with minimal or no training in counseling or therapy. Studies of MI for treating stimulant use disorder involve clinical staff who were trained in the approach. These clinicians were either trained community workers or bilingual peers, experienced substance use outreach workers who were themselves in recovery. Contingency management. The goal with contingency management, CM, is a type of behavioral therapy grounded in the principles of operant conditioning. Operant conditioning is a method of learning in which desired behaviors are reinforced with prizes, privileges, or cash. For treatment of stimulant use disorder, incentives behaviors might include attendance at treatment sessions, adherence to prescribed medications for other health conditions, provision of stimulants, negative urine specimens. In a clinical setting, reinforcement is often a form of vouchers that can be exchanged for retail goods and services. It may also include access to certain privileges, the opportunity to win a prize, or even direct cash payments. While CM may be structured in several different ways, two widely used approaches include the fishbowl method, where clients who have earned incentives draw a token from a fishbowl for a chance to win a prize of a varying value. Voucher-based reinforcement therapy, where the client earns vouchers for completion of desired behaviors and the level of vouchers increasing according to the escalating schedule enforcement. In a typical setting, a wide range of healthcare settings, including primary healthcare clinics, community outpatient programs, and inpatient settings, can use CM effectively. In addition, CM systems have been adapted to be computerized or web-based, facilitating access for people in geographically diverse and difficult-to-reach places. Studies include, in this evidence review, test effectiveness of CM for treating people with stimulant use disorder at community-based substance use or mental health clinics, private or university-run health clinics, methadone maintenance facilities, and community-based sites. Two studies had also had a web-based component of CM. Outcomes associated with contingency management. Studies include that this evidence review demonstrated to use CM for people with stimulant use disorder was associated with reductions in the number of days of stimulant use, stimulant cravings, new stimulant use, HIV risk behaviors. All outcomes were measured using either urine toxinology, participant self-reports, or addiction severity index scale. The time between treatments and follow-up varied from 0 months immediately post-treatment to 9 months. Demographic groups for intervention. Contingency management is used across genders, ages, race, and ethnicities in both individual and group settings. The approach can also be used with specific groups within the population, such as men who had sex with men, people with co-occurring opiate use disorders, and individuals with severe mental disorders. Studies include that evidence review involved adult participants were age 18 and older, had no language barriers, and met criteria for DSM for stimulant use disorder, either through screening or self-report. The practitioner types. A variety of professionals such as primary care physicians, behavioral health professionals, and criminal justice personnel can implement CM. Training or coursework in behavioral analysis is available to support implementation of this intervention. For most studies in this evidence review, research staff who may or may not have had clinical background implemented the CM procedures. Some students specify that these staff were trained and tested on CM protocols, often the use of the scripts or role play. Intensity and duration of treatment. Contingency management therapy does not have a prescribed time period, as it consists of reinforcement framework often used in a combination with other therapies. Many clinical evaluations of CM follow a 12-week schedule and feature frequent drug screening 2 or 3 times weekly. The community reinforcement approach. Goal 1 behavioral therapy approach is commonly used in combination with CM is a community reinforcement approach, CRA. This treatment was originally developed by Nathan Azarin and his colleagues for alcohol use disorder and was later adopted for stimulant use disorder, particularly cocaine use. The goal of CRA is to identify behaviors reinforcing stimulant use and make a substance-free lifestyle more rewarding than one that includes drugs and alcohol. CRA includes multiple elements such as analyzing client substance use, relationship counseling, vocational guidance, and job skills training. CRA therapy also focuses on building social and drug refusal skills. Ultimately, clients are encouraged to make substantial behavior changes, engage in new recreational activities, and develop new social networks. When used in combination with CM, clients who demonstrate positive behaviors such as drug abstinence are typically provided material incentives to encourage skills development to build a rewarding substance-free life. In the typical setting, the community reinforcement approach is often delivered through inpatient programs, home visits, and in combination with incentive vouchers. Practitioners can also implement it successfully in a typical outpatient treatment context where they see clients weekly at the clinic. Studies include in this evidence review tested the effectiveness of CRA for treating people with stimulant use disorder at community-based substance use clinics, public outpatient treatment facilities, and urban treatment facilities that offer both inpatient and outpatient services. One study also used an online CRA learning program. The demographic groups for intervention. The community reinforcement approach is used across genders, ages, race, and ethnicities in both individual and group settings. The adolescent version of CRA involves immediate family in the treatment program. There is also a family training version that aims to increase the client's engagement in the program through the coherence significant other. Studies included in this evidence review involved adult participation who were aged 18 and older, had no language barriers, met the criteria in the DSM for stimulant use disorders either through screening or self-report. The practitioner types. A variety of professionals who possess strong fundamental counseling skills such as supportiveness, empathy, and a caring attitude can implement this approach. This could include primary care and behavioral health professionals as well as pharmacists. CRA requires therapies to be directive, energetic, and engaging. For most studies in this evidence review, clinical staff implementation CRA by the following procedures outlined in the manual, a community reinforcement plus vouchers approach. Intensity and duration of treatment. Per the manual mentioned above, CRA recommends a 24-week treatment program. Each week, clients meet 1 to 2 times for counseling and submit 2 to 3 urine specimens. The goal with cognitive behavioral therapy is short-term, goal-oriented psychotherapy treatment that enables individuals to understand their current problems, challenges, and experiences in order to change their behavior and patterns of thinking. CBT helps clients develop accurate assessments of circumstances and their feelings so they can develop realistic strategies. CBT is used also to address depressive cognitives and other cognitive disorients associated with depression, generalized anxiety disorders, and substance use disorders. Through CBT, people with stimulant use disorders are trained to evaluate faulty patterns of thinking, action, and negative feelings associated with their drug use. CBT is tailored to the needs of the individual with the goal of each therapy session uniquely based on the client's experiences with stimulant use and personal circumstances. Computer-based cognitive behavioral therapy. A newer approach to CBT uses a digital format for delivery to the clients. This format draws on the National Institute on Drug Abuse CBT manual and offers CBT sessions either online or through an app. Computer-based CBT can be used in regular clinical settings as an effective supplement to usual outpatient treatment for stimulant dependence. Given the multimedia format of treatment, it is more affordable and can be made more broadly available than standard therapy treatments. Additionally, computer-based CBT can help reach and serve minority and geographically remote groups who may have limited access to such services. A typical setting. Practitioners can use CBT effectively in a wide range of healthcare settings, from inpatient to psychiatric rehabilitation to community outpatient programs. Studies include in current evidence review looked at CBT use in private healthcare clinics, community-based outpatient treatment programs, outpatient methadone programs, and through online formats. The demographic groups for intervention. Cognitive behavioral therapy is a widely used approach, employed across genders, age, race, and ethnicities. Studies reviewed for this guide included participants aged 18 or older who met the DSM criteria for stimulant use and dependence and who did not have any other mental illness or psychiatric disorder needing more intensive or targeted treatment, and only one study focused on men who had sex with men. The outcome associated with traditional and computer-based cognitive behavioral therapy. Studies include in this review demonstrated that CBT or computer-based CBT for people with stimulant use disorders were associated with reductions in quantity of stimulants consumed per week, frequency of stimulant used per week, risky behaviors of sex. All outcomes were measured using either urine toxicology, participant self-report, or the Addiction Severity Index scale. The time between treatments follow-up varied between 0 months immediately past post-treatment to 12 months. The practitioner types. A variety of professionals trained in CBT principles can implement it, such as behavioral health professionals, primary care staff, and criminal justice personnel. The National Association of Cognitive Behavioral Therapies offers CBT training for mental health professionals, as well as non-professionals with a 4-year college degree. And the studies include, in the current evidence review, trained clinicians delivered all in-person CBT sessions. Intensity and duration of treatment. Cognitive behavioral therapy is typically customized to the needs of each individual. Most people who seek CBT for stimulant use disorder receives counseling for a period ranging from 5 to 10 months. A standard therapeutic session approximately for 50 minutes. During this time, the therapist and the client work together to understand existing thought patterns associated with the client's current problems and develop strategies to overcome these concerns. Group counseling rarely utilizes CBT. Guidance for selecting and implementing evidence-based practices. Clinical issues to consider when treating stimulant use disorder. There are a number of issues that can present practitioners with clinical challenges and should be considered before making decisions regarding treatment planning. The table below summarizes the most common clinical issues encountered and strategies to manage them. The clinical use of a polyuse. An individual may use multiple substances to enhance the physical or physiological effects of each drug. To counteract the effects of one or more drug, the prolong of a drug effects, or to experience a new effect. The management strategy to this is to consider the pharmacological, psychological, and behavior reasons for combining certain substances, evaluate for the presence of other substance use disorders, and implement target treatment options addressing all substances for people who use multiple drugs. The clinical use for the overdose risk are individuals who intentionally or unknowingly mix stimulants with fentanyl have an increased risk for overdose. The management strategy for this is to assess the client of dangers from fentanyl and educate about the risks. Train program staff, clients, and family members on naloxone use and make naloxone available to clients, their families, and community. Monitor clients closely for opiate overdose symptoms from fentanyl or heroin mixed with methamphetamines or cocaine. For intoxication, the clinical use stimulants increase euphoria, hyperexcitability, hypersexuality, locomotor activity, agitation, and psychotic symptoms, including paranoia and hallucinogens. The management strategy is to talk down the client to calm the environment. For the client to exhibit severe symptoms of intoxication, consider pharmacological treatment, for example, benzodiazepines. For acute management of agitation and distress, antipsychotic medication for psychosis, paranoia, and hallucinogens. The clinical use for co-occurring disorders and stimulant use disorders. One of the challenges practitioners face in making a distinction between independent psychiatric disorders and psychiatric disorders as a result of stimulant use. The psychiatric symptoms that arise from intoxication and withdrawal. The management strategy for this is to consider the integrated treatment options regardless of the underlying cause for the dual diagnosis. Since the lack of adequate treatment for either disorder may interfere with an individual's overall recovery, coordinate services between stimulant use disorder therapies and mental health providers if stimulant disorder treatment staff do not treat mental disorders. Clinical use of psychosis. The stimulants can result in psychotic symptoms such as auditory or visual hallucinations and paranoia. Stimulation-induced psychosis is generally transient. However, methamphetamines can produce persistent psychosis like schizophrenia. The management strategy to this is to consider either benzodiazepines or an antipsychotic medication to address acute symptoms. Consider continuum of antipsychotic medication for long-term management of persistent psychosis. It can also cause violence. Methamphetamines use increases the chance of violence behavior. The management strategy for this is to be aware of the relationship between stimulant use and violence and be cognizant of the consequences of violence on individuals using stimulants, their families, program staff, and other program participants. Cognitive defects. Stimulants Misuse leads to attention and memory problems that can interfere with functioning and treatment approaches that involve learning. Management strategy. Inform clients about cognitive deficiencies. Use strategies that provide repetition of information and do not depend on optimal memory. Reverse treatments that require more complex cognitive functioning until the client's cognitive is restored after a period of abstinence. Stimulant withdrawal. As an individual stops stimulant use, he or she may experience symptoms like severe fatigue, insomnia, cognitive impairment, feelings of depression, anxiety, loss of energy, confusion, the inability to feel pleasure, and paranoia. Management strategy for this is to encourage rest, mild, moderate exercise, and healthy diet to manage withdrawal. Stimulant withdrawal. Individuals may experience cravings associated with specific cues such as objects, example given cach, people, example given drug user friends, other substances, example given alcohol, places, example given areas where stimulants are sold or used, time periods, example given weekends or after work, and emotional states, example given depression or boredom. Withdrawal may result in hypersexuality and impaired sexual functioning, leading to psychological distress. The management strategy for the stimulant withdrawal is to educate clients in treatments about the powerful impact of cue-induced cravings and help them identify strategies to avoid situations in which there are triggers. Educate clients about the possibility of change in sexual functioning during early recovery. The severity of disorder and level of care. Clients may receive treatment services at various levels within the continuum of care, levels ranging from prevention and early intervention to inpatient and residential services. Assessing the required levels of care for each client based on the severity of client's disorder is critical. The management strategy for the severity of disorder and level of care is to evaluate the client's needs and ensure that they receive services that are at appropriate level and then step up to more intense treatment or down to less intense treatment as needed. The implementation challenges and strategies. When implementing interventions to address stimulant use disorder, there are several potential barriers to consider. Issues related to implementing motivational interviewing, MI, contingency management, CM, community reinforcement approach, CRA, and cognitive behavioral therapy, CBT, include: number 1, practice selection; number 2, funding, financing, and program cost; number 3, program staffing; number 4, coordination of care; number 5, cultural adoption of the practice. The practice selection challenge: choosing the right intervention based on the severity of the client's illness and where they are in addiction cycle. The strategies are: the effectiveness of various treatment interventions may be influenced by the client's stage in the addiction cycle. It is necessary to consider the issues of psychosis and brain functioning related to active and recent stimulant use when choosing an intervention for stimulant use disorder. The MI can help clients decide to enter treatment and serve as a starting point in the recovery process. While often implementation successfully at the early stages of treatment due to its flexibility as an add-on component to other interventions, practitioners can apply motivational strategies throughout the recovery process. The role of implementation science in helping programs address implementation barriers. Implementation science is a study of methods to promote the uptake of proven clinical practices, programs, organizational interventions, and policies with the goal of improving health. The use of Consolidated Framework for the Implementation Research, CFIR, is one way programs can conceptualize construction associated with successful program implementation. Programs can use CFIR as a plan to execute new programs. The 5 main domains in CFIR are: intervention characteristics include the components and attributes of the intervention such as cost, strengths of evidence, and complexity. Outer settings consist of external factors that may affect implementation, including the policy and regulations in effect, patients' needs and resources, and the sources of implementation pressure. Inner setting considers the characteristics of facility contemplating implementation of a new program, including the organizational culture, available resources for implementation, and the facility overall structure. Characteristics of individual include the attributes of individuals making up the organization contemplating program implementation, and includes aspects like staff attitudes towards the proposed intervention, self-efficacy, and to adopt new programs, and perception of the facility itself. The process consists of strategies and constraints related to implementation, namely planning, engaging, executing, reflecting, evaluating. Constraints explain how a course of action for implementation is charted and carried out. Programs can use CFIR to identify both barriers and factors conducive to implementation. This allows programs to design a detailed strategies when considering new therapy practices. According to the Surgeon General Report on Alcohol and Drugs and Health, there are 3 stages of addiction are: Number 1, binge and intoxication, the stage at which an individual consumes an intoxicating substance and experiences its rewarding or pleasurable effects. Number 2, withdrawal and negative affect, the stage at which an individual experiences a negative emotional state in the absence of the substance. Number 3, preoccupation and anticipation, the stage at which an individual seeks substances again after a period of abstinence. Some interventions are better suited at the starting point of recovery within the early stages of stimulant misuse, whereas others can be tailored for the end of the addiction cycle, specifically for relapse prevention and treatment. CM can serve as a source of positive reinforcement for clients in the beginning stages of recovery. It can be combined with other therapies such as CRA and vouchers, and to enhance duration of recovery. CBT can be successfully applied at any stage of the addiction cycle or encompass the full cycle. CBT consists of various modules and add-ons, example given, homework that practitioners can specifically tailor to the client. The coordination of care. The challenge to coordination of care is individuals with stimulant use disorder may have other health care needs such as HIV or life situations affecting their health and recovery. Example is experiencing homelessness. Substance use disorder and recovery from them are often associated with social determinants of health such as income and housing instability. The strategies are: using a whole person approach. Practitioners need to coordinate treatment for stimulant use disorder with care for clients' other health needs. Models focused on care coordination, including physical, mental, behavioral, and stimulant use specific services, are more successful than those attempting to treat only stimulant use disorder. Whenever possible, co-location of stimulants use disorder treatment with primary care and other services allows for improved coordination between physical and mental health care. Other life circumstances, such as low income, experiencing homelessness, domestic violence, and child maltreatment, also affect the success of stimulant use disorder treatment. Coordination of care should encompass these social determinants of health, and provider should attempt to integrate resources and social supports from the client's community. Stimulant use treatment providers are well positioned to support systemic changes to address social determinants in their community. Providers and other stakeholders can identify gaps in services and promote additional resources to improve social and economic conditions of their clients. Cultural adoption of practices challenge. Behavior change interventions are most effective when they are responsive to the client's cultural practices and ideologies. When behavior change interventions are adopted to make them responsive to clients' needs, program staff may find it challenging to adhere the fidelity of the practice. They may find it difficult to maintain the core elements and fundamental principles of the practice during implementation. Cultural adaptation of interventions has been defined as a systemic modification of an evidence-based treatment, EBT, or intervention protocol to consider language, culture, and context in such a way that it is comparable with the client's cultural patterns, meanings, and values. Culturally adapted health interventions are more effective than usual care. These strategies include motivational techniques are adaptable for different cultures. The processes of change and motivational enhancement can be tailored to the values, beliefs, and experiences of individuals within different ethnic and racial categories. To ensure adapted practices are implemented with their core elements upheld, it is incumbent on those doing the adoption to collect rigorous data to assess the intervention for fidelity to the practice. When programs are not available to maintain fidelity and to establish practice, a rigorous evaluation of the adoption practice provides evidence of the impact of the adopted practice on stimulant use. For American Indians, Alaska Native communities, the focus of motivational interviewing on an equal or balanced relationship between the therapist and the client seems to fit well with cultural norms. Motivational interviewing can also be readily incorporated into tribal practices like talking circles and sweat lodge ceremonies. In addition to this introductory, overreaching implementation guidance provided in this presentation, there are several manuals and resources developed specifically to help stakeholders implement the practices. Please note that this presentation is not intended to be a training manual, but additional resources are available to support implementation of these practices. Motivational interviewing resources. Motivational Interviewing Network of Trainers, MINT, is an international organization affiliated with the development of MI, Bill Miller and Steve Rolnick. The website has resources for MI trainings and upcoming events. Contingency Management Resources, Motivational Incentives. A proven approach to treatment provides information and resources on the implementation of CM practices. This includes an initial training, an interactive online course, and free software for managing CM clients. Community Reinforcement Approach, CRA, resources a community reinforcement plus voucher approach. Treating cocaine addiction describes how to implement a CRA that adds a voucher component primarily with cocaine using populations. The manual describes the clinical treatment approach as well as tips related to the co-occurring psychiatric disorders and treatment supervision.